Good morning and a very warm welcome to this event on realizing the potential of transformative therapies, how to optimize cross-border cooperation to support equitable access to advanced therapies, hosted by the MEP Interest Group on Transformative Therapies. My name is Jackie Davis, your moderator this morning, and we're going to have an entirely interactive discussion after a welcome from our host and the presentation of a case study to inspire our discussion. Quick housekeeping point: if you have a question for our panel, you can write it in the Q&A box. Please be as brief as possible. We don't have much time this morning. We have a huge amount to discuss, but I'll try to squeeze them in if I can. And the Twitter hashtag, if you would like to tweet out, and we do encourage you to get that message out, is MEPs for ATMPs. Thank you very much. I'm now delighted to give the floor to Andre Knotek, MEP, who is co-chair of the MEP Interest Group on Transformative Therapies. We're going to hear from another co-chair after him. But Andre, thank you so much for hosting this event. Over to you.
Thank you very much, Jackie, for the floor. Good morning, everyone. And I would like to welcome all of you participants and speakers on behalf of the MEP Transform Interest Group today. As you know, the Transform consisting of the Alliance, the group of experts, and the MEP Interest Group simply intends to be the voice, as you said, to realize the enormous potential of transformative therapies through future-proof framework. Simply, we aim to deliver to our patients this one-time treatment and to maintain and develop this great high-tech industry in Europe. It is a great privilege to be informed by the experts of our alliance that based on our previous meeting in June on fostering the patient's access to the ATMPs, already the professional organizations are taking the consideration of our recommendation, and they put forward some of our recommendations. For example, for the acceleration of the payments of the cross-border or cross-border treatment, or for example, on the enhancing of the infrastructure and information centers for the ATMPs. Today, we would like to build on this successful previous event, revealing closer the possibilities how to optimize cross-border cooperation to support equitable access to the advanced therapies. And it is a great honor to welcome all stakeholders again, so the patient associations, European Commissions, regulatory authorities, and of course the industry to formulate concrete asks to the policymakers. As you know, the Commission is preparing the review of the Cross-Border Health Services Directive and the cooperation of different Commission DGs and of course national authorities is completely crucial to give the added value to our patients. We have approximately 5 basic asks which we would like to touch in today's debate. It's merging the authorization and reimbursement rules, extending the rule of European reference network, needs to upscale national contact points, development of pan-European infrastructure, and last and very not least, the funding. For example, through EU4Health, through dedicated call. I'm very pleased that already together with 19 MEPs, we began with 3, now we are 19 in the MEP Interest Group. We will carefully follow the debate and we will be ready to put forward all the outputs. So once again, thank you very much for today's event and for the commitment and dedications of all participants and stakeholders to make the goals of Transform happen. Thank you very much.
Thank you so much, Andre. And as Andre said, we're going to look at those key asks and discuss them in more detail a little later. Now delighted to give the floor to Alessandra Moretti, MEP, also a co-chair of the group. Alessandra, thank you for having us, and over to you.
Thank you so much, dear colleagues and friends, dear Andre. Thank you to the Transform Secretariat for organizing this event on such an important topic. In the recent past, we learned that the hard way the importance of health. We have seen that protecting public health has to be the #1 priority because it's the precondition for anything else, from our social life to our capacity of working, from the possibility of promoting development and growth to just enjoy a normal life around the ones we love. It's unfortunate that we needed a global pandemic to finally realize this, but now we must make the best out of this situation. We must put health at the center of our political action, both at EU and national level. At the European level, we have a major issue regarding access to treatments, not just innovative ones. The unacceptable discrimination among EU citizens in terms of access to prevention services and treatments, in particular innovative ones, has to stop. This is why I strongly believe in the project of the European Health Union, a common policy with a stronger coordinating role of the European Union, where the first priority would be to set up mandatory minimum standards in terms of health care services with binding benchmarks for member states. Of course, this is more the case for prevention services and more traditional treatments that should be widely available all across EU. In terms of innovative and transformative therapies, at this stage, it's not possible to have them available all across the EU. These specific therapies, as you know, need centers of excellence and very specialized infrastructures and personnel to handle them in the appropriate manner. For this, I think it's urgent to adapt the regulatory framework in order to guarantee access to life-saving and transformative therapies to everyone. We should act on every level, starting from the patients that we need to inform and involve in advance about these opportunities. We need to support clinicians and doctors through their associations in order to prepare the best therapeutic pathways in the interest of patients. We need to make it easier at the administrative level to assess treatments and the consequent reimbursement. It is a vast program, someone would say, but it is a needed program. Every day that passes is a day where some patient could have been cured, but it was not cured because its treatment was not available to him. And this is something we will no longer accept. I apologize with you for leaving earlier than planned, but I wanted to be here with you today to confirm once again my commitment to our common goals. Thank you, and I wish you all a fruitful debate. Thank you very much.
Thank you very much indeed, Alessandra. Thank you to both you and Andrea again for hosting us today and for reminding us just why it is so important to act on this issue and to act urgently. Fast, absolutely key. We're going to discuss how to do that and some of the specifics coming back to those key asks of the Transform Alliance a little bit later on. But before we do that, we want, as I say, to hear a case study, get some inspiration from on the ground as to the issues that we are discussing. And for that, I'm delighted to give the floor to Michela Gabaldo, who is Head of Translational Project Management and Regulatory Affairs at the Fondazione Telethon, and she's going to talk to us about Strimvelis. Over to you, Michela.
Thanks. Can I have my slides?
Can we put, there we go.
1 second. Okay. Good morning to everybody. I'm delighted to take to you this real case study of Streamvelis. Streamvelis was the first ex vivo gene therapy registered in Europe in 2016. It has been registered for the treatment of a patient with a severe combined immunodeficiency due to a lack of a special enzyme called ADA, so adenosine deaminase deficiency. And this is an ultra-rare indication, and this product has been developed at our center in Milan, the San Raffaele Teleton Institute for Gene Therapy, up to the clinical proof of concept before licensing to GSK in 2010, who industrialized the product, took to the registration and then to the market. This product then has been transferred to Orchard Therapeutics, who is the current marketing authorization holder. So this product, as you can see from the slide, is a very complex and articulated one that requires specific competencies to prepare, to manage the patient, prepare the product outside the hospital in a commercial manufacturing facility. And here we have the cells that are harvested from the patient, from the bone marrow of the patient. A subpopulation of staminal cells are selected, transduced with the correct working copy of the gene, and then reinfused back to the patient. The peculiarity of this product is that the product is fresh. So there are only 6 hours from the end of the production up to the end of the infusion into the patient at the bedside. And so as a result of this, the manufacturing facility and the hospital has to be co-located. So what happened in 2016 was then that after the registration at the European level, GSK negotiated with IFA in Italy the price reimbursement, and on August 16, the product has been put on the market with the ex-factory price of 594,000 euros. So, of course, at that time we are posing, we were in trouble because, of course, in this case, we have to change the paradigm because the drug could not be transported, and it was instead the patient that has to be transported to Milan, to our center, to receive access to this potentially life-saving treatment. And so we were questioning ourselves how to fund the treatment cost for this kind of drug and the clinical care, and how to support family and patient in moving. So for the first one, we did an in-depth analysis of the current European provision for the planned treatment abroad, and we will see in a second all the details. And in parallel, we put in place a broader internal project that is called Just Like Home, where we're trying to manage the patient in an holistic way so that we could help the family in overcoming everything that, all the roadblocks that could leading to the treatment in our center. In terms of current planned treatment abroad path, there are 2 current legal frameworks, the Social Security Regulation and the Cross-Border Healthcare Directive. And we did an in-depth analysis in terms of general principle, country variability, which kind of, prior authorization and which kind of costs could be covered and which hospitals are eligible for these 2 paths. And as a result of this in-depth analysis was that for the first one, for the Social Security Regulation, and this is also called the direct assistance because the patient is managed as it was insured in the treating country, whereas on the opposite, according to the directive, the patient, that is called also indirect assistance, and the patient has to pay in advance, keep the receipt of the payment, and then the reimbursement will be based on the tariffs established in the home country. In terms of country variability, we're expecting that the regulation would imply the same process, the same requirement, the same condition across European Europe, whereas the directive by definition has to be implemented in the national law, and so we were expecting additional special and national rule. In terms of prior authorization for the Social Security Regulation, the so-called Form S2, it is required always the approval. And in the case of orphan drugs, orphan treatment that cannot be placed on the market in the local country in a timely manner, medically justifiable, the patient can access, so has the right to request for the pre-approval form. Of course, it's up to the payer then to accept or refuse the funding. Whereas as opposite for the directive, in no case there is requested the prior authorization before the patient go abroad for the treatment. But there are some exceptions. So this is not the rule. There are some exceptions in case of prolonged hospitalization or highly costly treatment. In terms of cost coverage, both the parts we are covering the treatment costs, so the drug and the clinical costs, so the DRG, if the patient would have been hospitalized, or the clinical service associated to the treatment. However, there was a big difference among the two parts, because in the case of the Social Security regulation, the product has to be included in the country of treatment basket of care, and the tariffs reimbursed, paid would have been the tariffs of the country of treatment. As opposite, to apply for the directive, the treatment would have been have to be included in the home country basket of care, and the reimbursement would have been later on based on the home country tariffs. Neither part, neither the regulation nor the directive would cover logistic costs. Those has to be managed case by case. And then in terms of eligibility, the Social Security regulation apply only to public hospital or private hospital contracted with the national health system, whereas as opposite for the directive, any structure can provide this service. In essence, from this high-level analysis, we understood that the only viable path to give access to Strimvelis at our center was the Social Security regulation with the S2 form, because the money has to be anticipated by the family, provided, of course, that they have obtained the so-called S2 form. These are the actual numbers. So as per today, from 2017 up to today, we have received for 7 patients the approval, the S2 form approval for funding from Germany, France, Sweden, Belgium, and Spain. And so, in essence, what we learned from this case was that complex diseases require highly specialized clinical competencies that are not always available in your European Union, especially when you're going to ultra-rare indication. And complex therapies require concentration on knowledge, specific logistics requirement, training and qualification of the center that again may not be available in all the European countries. And so for the patient and for the whole ecosystem, it could be safer and most cost effective to move in these cases the few patients to the few highly specialized centers. And for sure, we need to do a greater cross-border cooperation to ensure this timely access. So as stated in the pharmaceutical strategy for Europe, there are an increasing number of cell and gene therapy under the development that brings potentially curative treatment. And this will require a new business model. And this model has to include a forward-looking perspective, leveraging from the key learning from real-life example like Strimvelis that effectively utilized the operating principle of the cross-border cooperation and interconnectivity. So realizing the therapeutic potential of transformative therapies and ensuring sustainable patient accessibility will only be possible by means of constructive and sustainable cross-border cooperation among all the different stakeholders, including in particular healthcare providers and national health systems. I would like to thank you very much.
Thank you very much indeed, Michaela, for that whistle-stop tour and highlighting there the complexities of the current situation, particularly with those 2 different pathways you were talking about for reimbursement and some of those infrastructure challenges with the nature of this highly specialized care and that importance of cooperation. We'll come back on all of these issues. Let me introduce our panel to discuss this. Delighted to welcome Tomislav Sokol, MEP, a member of the Transform Alliance and rapporteur for the European Parliament's Regional Development Committee report on cohesion policy as an instrument to reduce healthcare disparities and enhance cross-border health cooperation. So a topic very dear to Tomislav's heart. We are discussing today Caroline Hager, team leader and member of the Cross-Border Healthcare Expert Group in the Directorate General for Health and Food Safety in the European Commission, better known to most of us as DG Sante, Simone Bosselli, who is EU Public Affairs Director at Eurordis, Rare Diseases Europe, Christoph Ruprecht, Head of Department for Health Policy and Economics at AOK Rhineland Hamburg, a German insurer, Thomas Bowles, Head of Government Affairs and Public Policy for EMEA and Asia Pacific region at PTC Therapeutics, and last but not least, Mohit Jain, who is Vice President for Market Access EMEA at BioMarin Pharmaceutical. Very warm welcome to you all, lots to discuss, so let us jump straight in. And Tomislav, in terms of the challenges that we need to meet, if we are really going to ensure that we get this efficient, effective cross-border delivery and reimbursement, and crucially, ensure that equitable access that Alessandra was talking about in her opening remarks to all the patients who need them, what's the challenge here, Tomislav?
Thank you very much. Thank you first for inviting me. I think this is a very interesting discussion and a very timely topic. So when you speak of cross-border healthcare, there are many challenges, definitely. So first, the patients do not know what their rights are. So I think that is the first problem, the first step. So that this is something which is not really marketed by the member states. There are national contact points, but they all, in many cases, just provide minimum information required. So patients, most of the patients just don't know what rights are guaranteed to them by the European law. I think that's the first problem. The second problem that it is so very complicated. So we have two sets of rules, two sets of reimbursement coverage rules with different tariffs which are applied. So in case of Social Security coordination, state of treatment tariffs are applied. In case of cross-border healthcare directive, domestic treatments of the state of insurance. Then the problem obviously is also that you need under the Social Security coordination, you need to get prior authorization always, while in some cases under the directive you do not. Also under the directive, you have to pay upfront for the treatment and ask for subsequent reimbursement afterwards, unlike Social Security coordination, where you are treated the same as if you were in the state of treatment. So there you only pay the co-payment, which is paid by the people who are insured in the state of treatment. So there are big differences. There are additional requirements which are set by the cross-border healthcare directive. For instance, for prior authorization, in that case, can be refused if your domestic health insurance in your state of insurance, the things that providers in the healthcare state of treatment are not appropriate, are not good enough, let's say, to provide appropriate health.
An immensely complex,
which is not provided by the case of the Court of Justice. So there are many obstacles, and of course the problem of lack of infrastructure, lack of workforce, lack of different protocols and pathways, for instance, in cross-border regions, and also the problem of having such different health insurance systems, social security systems in different member states.
Absolutely.
So these are all the problems that exist. Of course, I don't know if we should speak about solutions already.
No, I want to come to solutions in a moment. First, I want to hear from everybody in terms of the challenge that we face. So underlining that immense complexity of the system, the different rules, big differences, and we'll come back on one of the key asks of the Transform group, that merging of the provisions.
And just one thing, I would like to add just one thing, which is also a problem, that if you want to get healthcare abroad, someone needs to decide in your health state of insurance that you cannot be given adequate treatment in that state, that you have to go abroad. And these people who are usually crucially giving these opinions are domestic experts who are providing domestic treatment.
Okay.
So they're always
can I stop you, Tomislav? We need to talk about all this.
Than the foreign treatment.
Absolutely. Lots to talk about. Thank you so much for that. Caroline, I know today with this review of the cross-border healthcare directive, that you are conducting. You're in listening mode, mainly to hear what people are suggesting, solutions to some of these challenges. But for you, the key challenge ahead.
Yeah, so thank you very much indeed. I think I'm really going to use these 2 minutes to complement and maybe add to what Michaela and Tomislav have already said. As you know, yes, indeed, we're carrying out the evaluation of the directive, which started in January. Many stakeholders have responded. Paying for treatment upfront is indeed one of the biggest barriers, together with the inadequate information, and the complex administrative procedures for prior authorization. And, these are issues that have to be addressed. And, but I think, from my perspective, most of the challenges can be overcome through better implementation by the member states. And this is something we've been doing for many years now, is trying to get the member states to take action to simplify their procedures. And in our report, we're going to be addressing this again for sure next year. Can I just make another point about the coherence, about the directive and the regulations? So I think Tomislav and Michaela already explain well the differences, but I'd like you to take into account this point. The directive centers on patient rights in cross-border healthcare. The social security regulations are wide-ranging. Healthcare is only part of them. They are about the coordination of social security systems. Therefore, when we talk about reimbursement, indeed, that's why the reimbursement for patients that are using the regulation route is taken care of between social security systems. Whereas in the directive, payment is upfront because, this is something that's not discussed. Why do patients have to pay upfront? It's because it was considered a necessary precondition to ensure the free movement of health services while respecting the member states to organize and finance and deliver their health care. So, it's a very different approach in the directive. And, I think we're certainly open to suggestions. But I think you also need to consider, is it justified to merge the two instruments, and what would be lost if you merge the two instruments?
Let's talk about that in a moment. Let's continue to build our picture of the challenges. Simone Bosselli, from a patient perspective, the key challenges.
Thank you, Jackie, and thank you to everyone for highlighting many of the challenges that we already have, and particularly Michaela. And I would like to point out to Caroline, and perhaps I'm going off my own script here, that when the Cross-Border Healthcare Directive was adopted, it was 11 years ago, and we didn't have a pandemic in between. Therefore, we need to still also recognize the times that are changing, and particularly also in the changes in the scientific developments that are currently taking place, that were so effectively illustrated by Michaela. And I would like to recall that since 2016, when Stream Valleys was adopted, we have had another 11 ATMPs that have been adopted if I remember correctly, and there are about another 35 in pipeline that should be coming in very quickly, addressing about a dozen of them, diseases with a prevalence of less than 1 in a million, which is exactly where the added value of European strengthened cooperation should be, not only in giving access to these therapies, but to creating the precondition for us as patients to be able to understand where the treatment could be, having the right coordinated recommendation for treatment. Obviously, the Cross-Border Healthcare Directive has introduced and created and set up the legal basis for the European Reference Network. And therefore, also, that directive has to be congratulated for putting forward a really forward-looking structure. But now we are in a different time.
Thank you very much. And that very much echoing what was said by Alessandra at the beginning, when she said every day that patients who could have been cured are not cured. We are losing time here in the face of this rapid scientific development. How do we keep pace with that? One of the key questions. You referenced there the role of the European reference networks, perhaps also national contact points in terms of information. So I'll come back on all of that later on, I hope. Christoph Rubrecht from AOK Rhineland-Hamburg. Very warm welcome, sir. What would you add in terms of challenges? Do you see them differently? Would you put the emphasis elsewhere?
Thank you for the opportunity to comment briefly. Europe must be a positive experience for European citizens. Cross-border health service is a lab of European progress. There are differences in the quality and excellence of healthcare between European countries as well as within a country. Social inequality, different individual financial resources, and the lack of health literacy lead to qualitatively different access to healthcare. Our data analysis shows these differences crystal clear, for example, in high-cost cancer treatment. Who can be against this fundamental idea, enabling safe and timely patient access to transformative therapies? ATMP is perhaps just a small excerpt, a past prototype, but an important starting point. It can be an important engine to enable all citizens of Europe to have equal access to good and even excellent healthcare in Europe. And I consider a further development of the European Directive on Patient Mobility worth considering. To access, I propose to think together about pre-authorization and payments. The need for pre-authorization in the home country for services could be reduced for certain clearly defined treatments, e.g. cell and gene therapy, for example, for a period of 6 years, that could be waived. Let's make a catalog for this. And reimbursement, this may require an European approach. A common European fund would be an option worth considering. Reduce the burden for the patient and for the European citizen, make it easier, quicker, and better.
Thank you very much indeed. Love to come back on those ideas. Could we develop a European fund? How would it work? Lots to discuss there. Let us continue. We're now going to get an industry perspective. Turn first to Thomas Bowles from PTC Therapeutics. Thomas, from your perspective, do you see the challenges similarly to our previous speakers? Is there something else you would highlight?
Yeah, thanks, Jackie. Yes, I work for PTC Therapeutics, and maybe we're sort of like a case study for what we're talking about, because we are a pharmaceutical company, a small pharmaceutical company, trying to come up with therapies for rare disease patients using gene therapies. So this combination of rare disease patients and gene therapies, I think, are the two key elements to what are the challenges around cross-border health, because it essentially means very simple that patients are in very small numbers all around Europe, but the treatment centers that need to apply these very innovative technologies are only based in a couple of countries. So I think already for the discussion, it's very important that we sort of really focus on probably that very specific case, because if you want them to provide access for these patients, it means patients will have to go abroad. So I would, and I have the feeling, and Simona mentioned this, legislation was developed indeed more than a decade ago. I think the situation was quite different then. And we see actually over the last 10 years, also to not always talk about challenges, but also positive things, that it has worked, right? There are patients going from one country to another, but we feel it is probably for fairly well-defined and with all respect, fairly simple operations like knee operations or hip replacements, etc. When it comes to these kind of highly innovative technologies, it is a different matter. And I think the issues, I think, and the challenges have already been talked about. And but just running through them, maybe add a couple to them is one is that indeed patients don't always know about them. I think Tomislav Sokol mentioned that, but physicians don't know this either always, that these options exist. And also, I think physicians should really also try to cooperate also cross-border more than maybe they do now. The systems and the tools that are being put in place, like the European networks and the national contact points, I think on the one hand do a really great job, but they probably have to expand their roles because they're too invisible and they're probably too narrowly focused on disease awareness and disease knowledge, and need to play a more active role in access to treatment abroad. So, and then I think the other thing is what very clearly, and we talked about this as well, is that at the moment when we see reimbursement issues, they're organized at a national level, and we need to get to a system where national reimbursement authorities can work also across borders, so to make this cross-border reimbursement a reality.
Thank you very much. Come back on that a little bit later. Mohit Jain, complete the picture for us, if you would, in terms of the challenge, and then we'll come to the solutions.
Thank you, Jackie. And I'd like to thank also the previous speakers that really set up the discussion very well. So I think it's important to kind of start off by considering that while some gene therapies require very specialist centers, some gene therapies, like in vivo gene therapies, don't require specialist centers and can be administered in various centers because they're normal infusions. But the infrastructure is important and the follow-up of patients is critical. But what that leads to is the larger challenge from our perspective, and much like Thomas Byam-Rin, is developing gene therapies for rare disease patients. And what we see is that with the number of ATMPs approaching launch, these require complex reimbursement arrangements predominantly and are negotiated at a national level. And these kind of complex arrangements can include payment over time, and payment based on performance, outcome-based contract agreements. Complex financial arrangements could include national patient caps or reimbursement conditions, such as sort of rebates over time. All of these conditions, as Thomas mentioned, becomes critical, therefore, for the cross-border healthcare legislation to consider the cross-border reimbursement implications. And these reimbursement implications therefore could impact patient access across markets. You know, there are implications for patients, whether when patients move from one country to a next country, how does that impact their reimbursement if they've been reimbursed in a target market and host market? And also, for example, how does it impact the host market if there's a national cap, when the national cap is based on national epidemiology, so the number of patients existing in that host country? And how does that impact also to the home country in terms of the incentives for reimbursement if patients are leaving that country? So these are complex issues. So really, I think in summary, I think there are large issues to resolve in the legislation in terms of guidance on reimbursement, as well as infrastructure. But to make the cross-border healthcare work, I think whether that is like a national European fund, or there needs to be a solution, probably a legislative solution, to recognize both cross-border reimbursement as well as cross-border infrastructure.
Thank you. So lots of ideas and suggestions there. We've enumerated the challenges very well. We want to come back on all those ideas. And just in terms of this, I think it was Christoph who talked about a catalogue. Developing a catalogue, and a question from Mark Dooms in our audience saying in the coming years, many ATMPs are going to be authorized by the EMA. Are we going to send all these patients across border? So that link between the two things. Let me just come back first, and I'm going to focus on reimbursement first, because many of your challenges that you've mentioned related to that, then we'll come to the infrastructure issues a bit later on. So we heard that call at the beginning, Andre outlined, for merging authorization and reimbursement. We heard Caroline indicating that this wasn't maybe as simple as it looked, that they are different types of beasts, the legislation, the directive and the regulation. Caroline, I think you had a workshop on this very topic, or on the topic of the directive yesterday. Did anything emerge from that that gives you a pointer to the way forward?
From the final stakeholder workshop that we had yesterday, no, we didn't get into the details of reimbursement issues, but what was raised a lot was the issue of information to patients and the role of the national contact points, not least the national contact points themselves, and this may be interesting for you to hear, would like to know better how they could work with the ERNs, because, you know, the patients come to them, they are the ones that are advising patients, and they need to have a better standing of the ERNs. And these are the kind of issues which are so obvious, and I think these are something we can definitely work on in the future.
Thank you. We'll come back on that perhaps in the infrastructure part of the session. But just in terms of reimbursement, the question Caroline asked at the beginning, she said they're very different approaches. Is it justified to merge them? Those of you who are advocating, and Michaela, perhaps come back to you here, they're different beasts. Can we merge them? Is there another way of simplifying the situation that might work?
Thanks, Jackie. I don't have a concrete answer, in the sense that I think that ideally we should study what was working well in the example that have used the cross-border, the operative principle of the cross-border, and try to, see whether it is better to merge or create a new path. I don't know, but the point is that we clearly know which are the elements that were working well and which one could prevent accessing the patient. So I will start from those analyses, in-depth analysis, and then define what is the, how is the solution.
And Tomislav, you were talking about those big differences at the beginning, but this importance of reducing the complexity of this system. What, in your eyes, what is the solution to this?
Yeah. So first, about the two systems, about the merging of two systems. So first, what is important? So the idea of merging only applies to authorization and reimbursement rules. So which means that other rules in the directive, like on ERNs, on telemedicine, on HTA, and whatever, will stay in the directive. So they will not become part of Social Security coordination because, as was pointed out, they are a different beast which has nothing to do with Social Security coordination. So this would remain in the directive. So we are only speaking about putting authorization rules into the regulation. And when we say that these are two different systems, yes, but what is important is that these two systems are complementary. So European Court of Justice said in the Van Brakel case in 2001 that these two systems of rules are complementary, and that if your entitlement, your coverage under your own domestic system is higher than under the state of treatment, so in the state of treatment you have to pay co-payment, which is bigger than in your home state, you're entitled to the additional reimbursement according to the rules of your state of insurance. So the Court of Justice already said that these rules are complementary. And what is important that both of these sets of rules are legally based on the rules on free movement. So Social Security coordination, free movement of persons, and cross-border healthcare directive, free movement of services. But these both sets of rules have the same legal basis. That's Article 114 of the treaty about internal market. So all of these are internal market rules. So so if you take into account that these systems are complementary, that both of these systems are based on internal market legal basis, on the same legal basis, then it's clear, I think, that there is no obstacle to merge them within the Social Security coordination, leaving the other rules on HTA, on ERNs, etc., in the cross-border healthcare directive. Of course, because why is this important? Because under the cross-border healthcare directive, you have additional obstacles and additional requirements, like for instance, the question whether the providers in the state of treatment are appropriate or not. You don't have this in the Social Security coordination. And these additional obstacles are put in a directive which are not part of the cross-border of the case law of the Court of Justice applying free movement of services. So this was put by the member states in the directive because they wanted to water down the rights which were guaranteed to the patients by the court. So I think that there is definitely room for improvement.
Thank you.
Room for simplification.
Thank you very much. Other thoughts in terms of this merger, or as Michaela was suggesting, other ways of doing it? She's saying she doesn't mind how you do it. We need to bring the rules together, whether it's by merging the regulations directive. Caroline pointed to some challenges there. A thought from anyone else on the panel, and then I want to turn to one member of our audience, Simone.
Yes, thank you very much. One of the things that I think is and I thank very much Mr. Sokol for the very deep analysis of how we can improve the legislative framework. A couple of things that I picked up today and we have done. I would like to thank Mr. Ruprecht for suggesting from German payers to have a European fund. This is quite important to do. I think this would facilitate in any way the potential for a patient to go across borders. That's one thing. Secondly, we need to continue to invest in this center of excellence to create those hubs, to make sure that those hubs become regional, not, continue to invest in this sense. And I think, Mr. Sokol, in your own initiative report, you might want to push for the better use of regional and structural funds to create those centers in any case. So I think this is really positive, and there are some of the stuff that doesn't need to be changed, is already there, and that we can build up on that whilst the legislative framework is being assessed.
Thank you. Mohit, I think you wanted to come in.
I think I just wanted to reiterate, I think that any system of cross-border healthcare legislatively needs to consider the implication of reimbursement of patients moving following treatment and how that translates into the funding of those treatments in terms of the risk-sharing arrangements which are existing in the host market. And I think that that requires the following of patients and the seamless following of patients, which I think is going to be a complexity moving forward.
Thank you very much indeed. Christoph, you talked about looking at further development, was the way you put it, of the cross-border healthcare directive. How do you see this challenge, and do you think a merger is the right way forward? Are there other ways we could simplify this system?
Well, I think the option to make a list without pre-authorization could be one topic. And this was also discussed at the beginning about the discussion about the patient cross-border directive. The other thing is what Mr. Boselli have mentioned. We need a structure of center of excellence spread across Europe, not just in Boston, in Paris or Berlin or Brussels. We need a pro-European network of center of excellence, which will also be places for the quality assurance introduction of innovation. We have to really think to more European-wide.
Absolutely, and I want to come back on that when we talk in more detail about infrastructure. Thomas, a quick one on this, and then I'm going to bring in someone from EUI. Thomas.
Yeah, no, very quick. On this question of merger, I think I can see there's a sort of ins and outs to it. I think if the overall aim is to simplify the rules, I think we would all be in favor of it. But my practical consideration was, at the moment, we're just talking about revision of the directive. So that's already one thing. And I think, as we discussed today, but also in other fora, the directive is actually not so relevant for what we're talking about today because of all the barriers that the directive brings up. So my call would be that merger or not, at least that we review the overall body of cross-border legislation. So that's a call to the Commission or others. And second, I think what is also quite clear is that you can probably regulate as much as you can through European legislation. For example, this pre-authorization was really introduced to respect the national competencies. But again, what we discussed today, a lot of the barriers at a national level. So we have to bring in somehow the national authorities, reimbursement authorities, etc., to complete the whole picture.
And we have a question relating to those barriers at national level I'd like to come back to in a moment. But before I do that, I'd like to bring in Dr. Ioana Psalti, who is a policy advisor at the European Alliance for Vision Research and Ophthalmology, EUI. And I have a question for you, Dr. Psalti. And my question to you would be the following. In your experience, what are the differences in healthcare systems about cross-border referrals? We've been hearing time and again about that equality of access. How do you see the pattern in terms of the differences in different countries? Because that is absolutely crucial to the success or otherwise of attempts to ensure genuine cross-border access. Dr. Psalti.
Good morning, Jackie, and everybody, and thank you for the question. What the perspectives of the ophthalmology community when it comes to cross-border care is that the success depends on the type of reimbursement system that exists, if it's universal or insurance-based. And insurance reliance is a disadvantage for a country because it depends on the package the individuals have. Another dependency within the referral system is how well is the European reference networks are integrated in the national referral system. The Commission has produced recommendations. Now, this is kind of like quite important because in Greece, there is a national process for cross-border care. It's very well established, it works. But the people who are involved in the approval of the social security, the confirmation that the disease is cannot be treated in the country, they're not even aware of the existence of the European reference networks. At least they were not when I asked them yesterday. So we all assume awareness about these cross-border rights at patient and doctor level, and also skills in navigating the referral system, because the cross-border referral system is different to the national system. So our view would be that to improve the cross-border access to any therapy, we'll need a holistic approach, from making it mandatory that countries inform patients and doctors, and that cross-border care is also introduced as a concept in the medical training, including the skills to navigate the system. Thank you. Thank you.
Thank you very much indeed, Joanna. Great to hear from you. Caroline, a reaction to this discussion we're having. So people saying the goal here is simplification, reviewing the overall body, whether it's a merger. You indicated and you some problems and you said, is it justified? Your reaction to this discussion and on the idea of a common EU fund. Annie Hubert asked from the audience, do you believe there would be a need to discuss reimbursement at pan-European level rather than at national? And if so, how would you make this possible, particularly when considering the confidential nature of market entry agreements, such as outcome-based agreements? So two issues really there. We've heard these calls, these suggestions that a common EU fund might help, but also, I think it was Thomas who said it earlier, reimbursement organizations really need to work together better on these issues. Your reactions on both points, if you would, Caroline. Just that.
Yeah, okay, yeah. So I think it was very useful to hear all the different perspectives, and I think a number of points were made again about the role at national level and the member states, and indeed the reimbursement authorities working together. I mean, at EU level, we have a cross-border healthcare expert group which brings together those that are responsible in the ministries, and there are also a large number of national health insurers in that group as well. So these issues, of course, we're going to be discussing once we have adopted the report on evaluating the directive. And even though the report will include a forward-looking reflection on the future of the directive and whether it's still relevant for needs, patient needs, and of course the discussion today is no, it's not, certainly not for patients with ultra-rare diseases, then we will start discussing solutions such as maybe a common fund or whatever other steps need to be taken. So, you know, it's important for us to hear what is felt by the stakeholders and the European Parliament, what could work. And yeah, so there'll be further discussion on that, I think, in the future. I don't think, yes, and I think another important point was raised regarding the European reference networks. Indeed, this is another issue for rare disease patients, is the integration to national health systems, and that there's no patient referral system. And this is something the national contact points find very difficult when they want to advise patients how they can be referred, because as you know, referral depends on the treating doctor, whether they're going to refer the patient to seek healthcare in another country, and do they have an incentive in doing so.
Thank you very much. Tomislav, a quick reaction on this and this idea of discussing this at pan-European level. How could we do it, was the question from the audience. And then I want to bring in and come back on some of these infrastructure points. Caroline was again just touching on them.
Yeah, actually, I was advocating when we were making a position paper on healthcare in my political group in the EPP, the idea of creating a pan-European fund financing cross-border healthcare. Of course, we would need to have an analysis of the overall size of this, but this is definitely something that should be on the table, even though I think it's not realistic within this budgetary period. But we should start creating atmosphere on this, because one of the main problems with strengthening cross-border healthcare is the financial burden placed on the national health insurance funds, and this is something that's always been the main problem and main reason for all the obstacles that were put against the cross-border healthcare on the national level by the member states. That's my first point. My second point about the integration and the European reference networks. What we have proposed as the EPP as an amendment on the draft report on beating cancer plan is the so-called right to second opinion. So the idea is that if your domestic experts want to prioritize their own choice of treatment that they're providing at home, to use the European reference networks to get a second opinion from a doctor from abroad, from another member state, would be in a more objective position to say whether an adequate treatment can be provided in the home state or the patient really needs to go abroad. So this right to second opinion is something that will be discussed in the Parliament in the future, definitely, and I think it will become the part of the draft report of the beating cancer plan. That's the second point. The third point, cross-border contracting. Because the problem is that patients have to go through all of this by themselves. But if health insurance funds from one state can enter into contracts with providers, with hospitals from other member states, then they can organize, they can set up organized pathways for patients to go abroad without the patients having to ask for authorization, pay upfront, etc., etc. So to create an organized system, and for that we can use this whole idea of having regional centers of excellence, which is the main focal point of my report on how to use cohesion policy funds. So not to have one center per member state, which would combine everything for a certain disease, but to have regional centers, specialized centers, which will provide healthcare for border regions. For instance, if Zagreb has a good center on the liver transplant, why wouldn't this center enter into contracts with health insurance fund from Slovenia and Hungary, for instance? And why wouldn't they send their patients in an organized way to Zagreb to get healthcare there without having to go through all of these procedural obstacles? So this is very important. And the last point, cohesion policy. We always, in financing, we always speak of the EU for Health program, which is a very good thing. It's 12 times bigger than the previous budgetary program, so that's 5.3 billion euros. But in the previous budgetary period, 2014 to 2020, 25 billion euros was spent for healthcare infrastructure from the cohesion policy, 5 times bigger than EU for Health program, which means that there is a big untapped potential of using this in a more organized way to actually prioritize most important things in the area of healthcare provision, cross-border healthcare, and to build this infrastructure in border regions and really facilitate access for patients to healthcare.
Thank you very much indeed. Let us then begin to focus more. We've already touched on a lot of these issues relating to infrastructure, but Simone Bisposelli, you talked at the beginning and you were talking about, creating the preconditions for patients to understand where their treatment could be. In infrastructure terms, what do you see as the key issues we need to address first? What's the priorities for action in this area?
What Caroline said, really, the integration of the European reference network within the national healthcare system and appropriate referral pathways, systems that allow for the patient that are eligible to access treatment elsewhere, to actually use it in a timely fashion. What I think we haven't been discussing now is something that Michela at the very beginning pointed out. In some of these therapies, timing is of the essence. And Michela and I have been struggling on at least 2 occasions to get within a very short time to get this paperwork sorted. I very much agree with Mr. Sokol that those pathways between countries and health insurance should be looked upon. And there are already examples, I believe, also Hungary and Austria work on bilateral contracts in specialized care, particularly around heart surgery, if I'm not mistaken. And this is contained in some of the reports from the European Commission. So those pathways do exist. And additionally, we're not talking here about, and perhaps this is something for national competent authorities, we're not talking about reducing the health competence of the actual member states, but increasing the quality of the actual infrastructure. And it's great that we have that much funding potentially available, and particularly for rare diseases, the technical and the technical expertise, it is not contained in every single member state. We need to improve it. We need to have, Joanna mentioned it, much greater knowledge disseminated also within the medical profession, but it clearly general practitioners won't be seeing all of the 6,000 rare disease in the course of their life. That's what we need to do, making those centers really qualitative, making sure that they improve their capabilities, and the capabilities are spread around Europe.
Thank you very much. Other key issues we need to address, Christoph, and then I'm going to bring in a moment a couple more Transform Alliance members and ask them a quick question. But Christoph, how do you see the challenge in this area?
2 things. One thing, we need not only specialized, we need uniformly certified and specialized centers of excellence for Europe. This is one thing. The other thing is,
I'm sorry, who would do that certification? So we need at EU level to create?
I would propose this. We have this in Germany, but I think we need it on the European level.
Yeah.
You have this, for example, for Comprehensive Cancer Center in Germany, but I think it's not possible to have different certificates. Nobody understands this. So that's the other thing is the idea to make access for everybody in Europe, independent where you live, in Croatia, Germany, France, Spain, Romania, wherever. I think it's an excellent idea, and we have really to fight for this. And of course, it's difficult. Always, also if you discuss directives or something like this, but the idea make it easier and perhaps more mandatory.
Thank you very much. Other thoughts to this before I bring in? Let me bring in now Dr. Giovanni Migliaccio, Scientific Director at CVBF, the Centro Valutazione Biologiche e Farmacologiche. Giovanni, if you can hear me, what is the role for you in terms of, we've heard so much about the importance of these specialized infrastructures and the challenges that are posed. How do you see them from the perspective of pediatrics care?
Thank you for the question. I would like to see from a different point of view. You know, a new drug needs between 1 and 2 billion to reach the market in a safe and controlled manner. This makes new treatments for small patient population very expensive and difficult to be reimbursed due to the high cost, especially for ATMP that are very innovative. The risk of failure is high. Furthermore, when you use this for rare diseases or small population as children, that leads to very high cost for treatments. The European-wide research infrastructure, pooling national resources and achieving the required economy of scale, allows academic, SME, foundation to access specialized, expensive and controlled technologies that are required to put a new drug safely on the market. However, there is no legal framework integrating research infrastructure in the support of industry standard, non-profit drug development, which reducing the cost of the final drugs would facilitate the issue of reimbursement. So across border will be easier, company and insurance will be much happier to reimburse this product and facilitate their use.
Thank you very much indeed. And let me also turn now to Amanda Bock, CEO of European Haemophilia Consortium, EHC. And together with the Association for Haemophilia and Allied Disorders, Amanda, you've been working on promoting a hub and spoke model for treatment of haemophilia and rare bleeding disorders using gene therapies. Can you tell us a little bit more about the idea? Where are you in the process?
Thanks, Jack, and thanks everyone. It's a very interesting discussion. So regarding these questions around infrastructure and centers of expertise, it's important to note that hemophilia is in a rare disease space that has a long established history of having hemophilia center accreditation at 2 levels of expertise, comprehensive care and standard treatment. So there's a long pedigree of expertise that's already centralized. And we also have ERNs. And nonetheless, we feel that neither of those systems are enough for the introduction of gene therapy. Both the healthcare provider community as well as the patient community feel that we need a more bespoke hub and spoke model for these gene therapies. And the reasons include some of the aspects that have already been mentioned, including having the appropriate expertise on board, ensuring the safety and the monitoring. So we're currently exploring what this would actually look like. I cannot tell you right now what it will look like, but I can invite you next Saturday, the 20th of November, to a public, open and free virtual attendance of the EHAD-EHC roundtable on the hub and spoke model for gene therapy, specifically in rare bleeding disorders. So this is going to be one of the first multi-stakeholder conversations about what this would look like specifically. And more broadly within our new think tank, we are working on modeling for what this might look like in a broader innovation field that includes but is not limited to gene therapy. So certainly something that we're currently busy with.
Thank you very much indeed, Amanda. Panel, reactions and thoughts in terms of how best to address the infrastructure issue. And we've talked a lot about information. And Johan Prevot from the audience says patients are often not really aware of their rights until they are confronted with the situation. Their main source of information tends to be treating physicians more than national contact points. Beside the obvious role patient organizations can play in disseminating information to their communities, what measures could be taken to ensure patients have better access to clear and timely information in the context of cross-border access to advanced therapies? Please do react on that. And this whole information, how do we upscale national contact points? What do we need to do? How do we use the European reference networks better? Crucial questions which you've all raised. Michela first.
Thanks, Jackie. I think that for sure we have already discussed and proposed the fact that the national contact point has to be trained on the peculiarity of this kind of innovative and transformative therapies and why they are different from the traditional drugs, first of all. Second point, I think that, and again, coming to the example that Simone were mentioning, that we are struggling for months, I think that national contact point could play a key role in making transparent the funding and the approval process at the national level, so that you know we stuck for months to understanding which were the board that have to sequentially approve step by step the final treatment. And here we are speaking in the majority of the case of life-threatening condition with a very narrow therapeutic window, and so this delay. And we have cases, unfortunately, that delay that preventing them accessing the treatment. So, you know, I think that national contact point could build transparency at the European level on the approval process.
Thank you very much. Other thoughts in terms of how we can beef up the role of the European Reference Network's contact points or other ways of addressing these issues? And then I want to come to broader questions of funding, and I'm going to bring in another member of the Alliance from the floor. Tomislav.
Yes, I already mentioned one. So to use them to get this right to second opinion. So in this way to incorporate them in the whole prior authorization procedure. I think that is crucial, because I know many obstacles where you have domestic experts who are in kind of a conflict of interest because they're inclined to prioritize their own choice of treatments that they provide by themselves when compared to foreign treatments. So I think this entitlement to second opinion, to actually get a European opinion on what is the best possible treatment, would be a big step forward for the patient, because in many cases prior authorization is refused because the domestic experts say that they provide better treatments at home than are provided abroad. So I think that's a very important point. Plus the other things that I already mentioned, like cross-border contracting, making it organizing the pathways that the patients do not have to go through all of this by themselves. And of course, what is very important to actually provide in the relevant rules, Social Security coordination or the directive, the obligation on the member states to proactively provide all the information for patients about the possibilities that exist. Because now this is interpreted in a very narrow way. So just most basic information provided by the national contact points, usually in only one language, which is a big problem for patients. To actually create an obligation for member states to proactively promote these possibilities which are provided by EU law.
Thank you very much. Caroline, you mentioned that this was the focus of the conversation at the workshop yesterday. In terms of the Commission's role in all of this, what you can do to help in relation to information to patients, to beefing up the role of NCPs and European reference networks, how do you see that as we move forward?
Yeah, so I mean, I think this is something we've been doing for a number of years, of course. And clearly more needs to be done. I mean, information has improved, but we know already from the findings from the study supporting our evaluation that, there's still really huge information gaps. For example, I think Michela mentioned the issue of transparency, making it transparent which categories of healthcare are subject to prior authorization, where they can find information on the procedures for prior authorization. This is where really on many NCP websites, this information is still lacking, or it's presented in such a way which is very difficult to find. So we will continue to work with it as follow-up, to the evaluation next year. I mean, there are going to be a lot of action points to follow up with the national contact points. And could I just say, there is an openness amongst the national contact points to improve. They would like to know what are the details, what they could do. And, you know, they are really open to making changes. But there are also those that lack resources because the national contact points are very different. Some of them are really just a small part of the health ministry or an health insurance fund. And, you know, they still lack resources, I think, in order to fulfill some of the higher expectations now that are coming from patients and others such as yourselves as a result of the directive evaluation. So I think this is something we also need to look at. And on the issue, can I just come on to the second opinion?
Of course.
Tomislav, yeah, I think this is really a very important point indeed, because I was just looking at the directive and, you know, according to the directive, it's the member state of affiliation, so where the patient is insured, that could request scientific advice in the case of rare disease patients, but there's no possibility in the directive for the patient. It's not made explicit anywhere as far as I'm aware. For the patient to seek a second opinion. So I think this is something that certainly deserves further attention.
Thank you. Any other?
If I may just add a very quick sentence. Actually, the European Court of Justice made a judgment about a month ago.
You're right.
Where they mentioned for the first time this entitlement to second opinion. So we are on the same track as the European Court of Justice, but we need to make this explicit and organize it and provide it and prescribe it in a systematic manner. But European Court of Justice is already going in that direction.
Yeah, no, you're absolutely right, Tomislav. Thank you.
Thank you very much. I want to bring in another member of our audience who wants to talk more broadly. We talked about a common EU fund in terms of reimbursement, but slightly different point. Harun Savic, committee member and survivor representative at Childhood Cancer International Europe, CCI Europe. And Harun, I wanted to really ask you how you see the role of funding programs like Horizon Europe in promoting another aspect of infrastructure, education, cross-border, disciplinary and patient-centered education training. We've talked a lot about the training aspects of this. How do you see the role of programs like Horizon Europe?
Good morning. I thank you for the opportunity to answer this question on behalf of childhood cancer community. First, I would like to give our opinion as I must flag the lack of research on innovative treatments for childhood cancer. A distinct funding research project on innovative transformative treatments are urgently needed in pediatric oncology fields. When it comes to cross-border healthcare, I think we need to accelerate networking between hospitals across Europe that treat patients with innovative medicines so that the patient can get the necessary medicine.
Thank you.
I have more to say, and in addition, exchanging expert knowledge between healthcare professionals in a cross-border setting is pivotal for rare disease patients. However, in order to truly advance, we require a sustainable funding goal for ERNs to broaden access to innovative medicines for rare disease patients like pediatric cancer. And furthermore, we should meaningfully address the European non-EU countries with the cross-border healthcare directive, where the non-EU countries have to fund innovative medicines from the EU member states, which is a lengthy process. And most of the times we are not even certain that we will get the medicine.
Thank you very much indeed. I want to take a couple of specific questions from the audience, and then I want to ask you to identify ways forward. And let me take one that links to what we were hearing there from Harun, because linking to cancer. Miriam Krull says, will the MEP group look not only at ATMPs for ultra rare diseases, but also at those for diseases with a high incidence such as cancer? She points out the prices of these treatments are a big threat to equal access because of healthcare budgets in lower income regions of Europe that aren't significant to carry. She says patients paying up front, waiting for reimbursement on return home is unacceptable. What can be done? Tomislav, is this something you are looking at?
Yes, that's precisely the idea of merging the social security coordination.
She's asking specifically with reference to oncology.
to avoid paying upfront. So
Yeah.
because in Social Security coordination, you do not have to pay upfront unless for the domestic co-payment in the state of treatment. So this is the main purpose why we want to have this. And the other is cross-border contracting, also to avoid patients having to go through all of them by themselves, but having the health insurance fund making all the cross-border arrangements. So that is precisely the idea of proposing these two measures. Which
so just to reiterate, it's not just rare diseases here; it's also areas like oncology, which was her concern.
Oncology, yeah. I mean, we propose this both sets of measures within the SDPP in the amendments of the draft report on Europe's Beating Cancer Plan. So,
Thank you, Vincent.
So this is the first concrete area where we actually are proposing this, but of course we'll do this in other areas as well.
Thank you very much. Another issue Vincent Clay from Novo Nordisk raises is, given the complexities of treatment with some ATMPs, cross-border access to trials is an important issue alongside access to authorized treatments. He says there's a useful paper on this, which he points to. Is this an issue that you are considering? Christoph, I see you nodding. Is this an issue you're looking at?
I suppose that it's a common idea to make it easier in Europe also for clinical trials and have federated platforms. In such a way, perhaps we can go. But the other thing is rare disease is not really rare. So we have to be aware about this. And also that we have to know that the innovative development comes faster and faster. That's the reason we need really center of excellence for where we can quality assured introduce innovation. And this means also we have to strengthen Europe in this case. The other thing is the cost is the main hurdle. Not forget this. The information will follow this. And I think the European reference network or contact points are not enough. So the physician should know about that. So we have in the John Phil committee, if you have introduced a new drug, after some months, everybody knows, every physician knows about the quality of the new drug treatment. And I think we need more fluid system in this case too.
Thank you. Any other quick comments to that before I want to put you all on the spot before we close?
If I may just add, yes, the problem of clinical trials is that in many cases, smaller member states like mine are excluded from these big clinical trials, which involve bigger member states. So we have to provide some kind of a framework of European framework to also include these kinds of countries. But what is very important when you speak of cross-border trials is data. So how to create interoperability of data in different healthcare systems, and for that reason, I think the future regulation in European health data space is very important. So without the possibility to use data in cross-border setting and to exchange data and have interoperability and compatibility of health data, we cannot really speak about real cross-border healthcare and cross-border clinical trials. So this is also something which is very much connected with the topic that we are discussing today.
Thank you very much indeed. We are almost out of time. Tomislav, I'm going to come back to you at the end for some final reflections, but I want to be slightly unfair. I just wanted to go back because Alessandra Moretti said in her opening remarks, she talked about the urgency and said, you know, every day that we lose in addressing these issues is another day where patients who could have been cured are not cured. So for each of you, if we are to really address these issues of reimbursement, of infrastructure, all the challenge we've talked about, and thus realize the full potential of transformative therapies, what is your key priority for action? And I'm going to go backwards to the way I started. So Mohit Jain, you first, and it's under a minute each if you would. Sorry to be so tough.
I think that a critical aspect is the cross-border contracting and monitoring of patients. So being able to follow patient data across borders, and I think that refers to the importance of the hub and spoke model, the ability to move patients and patient data, and contracting across borders there. So that's I think that if we can do that, that would be really important.
Thank you, Thomas Spolz.
Yeah, two things. One is, as I said earlier, really, I think the review of the directive is a good start, but I think we need to review the overall legislation. So that would be my But we all know that will take a long time as well, even if we would achieve that. So in terms of urgency, I think also it would be good to create, and I don't know if the Commission can do this or this, the intergroup or whatever, to create some platform where we bring all the stakeholders, in particular also the national health insurers and ministries of health, to find maybe sort of, let's call them interim solutions while we look at the European legislation to improve it.
So really echoing Caroline saying earlier, there's a lot we can do in implementation terms. It's the member states who have a lot to do. Let's do that, but not lose sight of the overall long-term goal as well. Christoph Ruprecht, your key priority now.
3 things: reduce the financial hurdle, e.g. like a fund. Second, quality assured introduction of new innovations. And third, the information should come to the patients.
Thank you very much. Simone Boselli.
That's really cool. So that I can close it just before Tomislav. The main things that I want to refer to is actually to quote the Italian president of the Senate Committee on Health, who recently, at the occasion of the adoption of the Italian law on rare diseases, said that the justice of a health system is measured by the way that we treat the rarest of the diseases. And this is how we should really look at things, in the sense that when we look at the edge of the scientific and medical science, such as on a rare disease, we can push the boundaries of policy, legislation, and so on. In this case, I think what Alessandra Moretti earlier said, starting with cases of rare diseases, to set up minimum health standards across Europe with minimum requirements, pulling together all of the standardization of even contracting, if that is the case, but also negotiation, potentially even joint procurement, then we can start making a difference for everyone else too.
Thank you very much. Michela Gamaldo.
In addition to what the other have said that all elements are very important, I would like to add 2. The first one is increased transparency. This is, an immediate action that can remove in the short term, while all the other changes in the legislation are done, can remove the bottleneck. And second, of course, here we are speaking about timely access. And as I was saying, timely access means the difference between potentially life-saving treatment or not, because a life treatment can be potentially life-saving if it is reaching the patient. If we are not reaching, of course, is a waste of time and effort. So in this case, any change that will be implemented, please double check that we are not regulating in such a way the system. So because here the aim is to simplification and not additional roadblock.
Thank you very much, Michela. Caroline, a final thought from you. I know you're more in listening mode, so you may not want to identify a key priority, but a final thought before I hand back to Tomislav.
Well, I think I've made the point several times in that, I think what's a key priority for us is to keep this momentum up. I think, several mentioned the COVID pandemic, that has seen a really substantial incentive for member states to cooperate more closely together. And I think, this collective effort remains really important in all areas of health policy, which is why the Commission is also working on a European Health Union, as you know very well. And I think our cooperation with the European Parliament and the MEPs also incredibly important to keep the momentum going. Probably not fast enough for many of these rare disease patients. So I think I just wanted to agree, improving information, we need to continue with the national contact points, what can be done to simplify things, as well as with insurers, simplifying administrative procedures and the length of the procedures and the length of the time it takes to respond to requests for prior authorization. I think we really need to keep up the pressure there to speed up these prior authorization procedures. I think I could go on, but I'll just make those.
Thank you very much indeed. Tomislav, your key priority, and then some closing thoughts from you on the way ahead before we bring this webinar to an end.
Thank you very much. So I'll try to combine this in a single point. So what I think is crucial that we use the current competences and current rules, current sets of rules that we already have on EU level, and to improve them to make it easier for patients to access healthcare abroad. Because we already have legal framework. We don't have a problem of competences because the legislation is already there. We just need to make it better, to simplify it. What is important is to simplify it for patients and to create an organized system where the institutions, health insurance funds would be the ones who will do all the work instead of the patients themselves. I think that is crucial. And by doing this and providing all the necessary information to patients, we would resolve the problem of the current problem that now only the well-informed and well-off rich patients are those who can fully benefit from cross-border healthcare. So I think to create this organized system and to use and to amend the existing legislation is crucial. And second, to use the EU funding that we already have at our disposal, especially cohesion policy funds, to reduce these inequalities that exist and to build the real health infrastructure, especially in border regions. I think that is very important. That this can be used in a much better way. And what is important there when we speak of cohesion policy, to use health outcomes, health goals as benchmarks when assessing how EU cohesion policy funds are spent. Because by doing this, we can force then member states to actually look at how to best use these funds to improve their healthcare systems. So to have these healthcare outcomes as benchmarks when assessing how the EU cohesion policy money is spent. I think these are the two most important points. The step forward, of course, you know how the system works. The Commission is the only one who has the right of legislative initiative. So the Commission needs to propose the legislation. So I hope that their revision of the directive will finish as soon as possible, and that they will come up with some concrete legislative proposals, and that we can really start working on this in the next year, because now we are in the middle of the mandate in the European Parliament. So now is the best way to actually, at the last minute, to start doing this. Because if we wait for the last 6 months before the European elections, nothing will get done, and everything will be postponed for the next session of the Parliament, and this is something that we do not want. So my plea is for the Commission, so you know what the priorities are. You're conducting the revision. You will have all the necessary information, all the inputs from all the stakeholders, and we expect concrete legislative proposals next year so that we can really adopt everything that we need by the end of this mandate of the Parliament and the Commission.
Thank you. And Tomislav, from the point of view of the Alliance for Transformative Therapies and your interest group, I think you've got more discussions coming up, more activities, and you're open always, as I understand it, to new members who want to join your work. Is that right?
Yes, yes, definitely. So what we are trying to do is to build a very broad alliance in the European Parliament related to European Parliament on this topic, and of course to include as many stakeholders as possible. Because what is important, what Caroline mentioned, the momentum the atmosphere and the momentum have changed. So before COVID-19 pandemic and Europe's Beating Cancer Plan, healthcare was a marginal topic in European institutions. Let's be clear. So healthcare was not considered one of the most important issues and topics in the European institutions. This has all changed. Now we have focus on healthcare. All the European institutions are thinking on how to improve healthcare systems in Europe, and we should use this momentum to really make concrete improvements.
Thank you very much. And just to say, ladies and gentlemen, that the next Transform MEP Interest Group meeting is scheduled for sometime in March or April next year. More information later about the date. And next year, the plan is to focus the work on access, in particular models for access, the regulatory framework, given the forthcoming review of pharmaceutical legislation and the legislation on blood, tissues and cells, and the use of real-world evidence and how this is critical along the lifestyle of a therapy. So we are out of time. I wish we'd had twice as long for such a fascinating discussion, but thank you all very much indeed for your thoughts, your contributions. Thank you to you in our audience for being with us, for your comments and questions. Thank you to those Alliance members who joined us from the floor. It only remains for me to wish you all a very pleasant rest of the day. Thank you and goodbye.
Bye-bye.
Bye.